Hello, my name is Becky Gerber. I am currently at Carolinas Medical Center, which is with the Wake Forest now in Charlotte, North Carolina. Here are my disclosures. So my goal today is to go over the preoperative, intraoperative, and postoperative pathway for my HoLEP patients. So I learned HoLEP in residency, but I think it is a very feasible thing to be able to learn in practice. Both of my mentors that I learned it from learned in practice. I've taught my partner how to do it in practice, so I think this is a very useful tool to have in the armamentarium of a urologist, and it's very feasible to be able to learn it while in practice. There are so many reasons I think that HoLEP is a great procedure to be able to perform. It can be done on any size gland. It can be done on patients on anticoagulation. It can be done on patients in retention, and the retreatment rate is incredibly low. It's less than 2% at 18 years. So you're really giving people a significant improvement and a durable improvement in their quality of life. And so while it might take a little bit of investment to learn it while you're in practice, I think it's worth it for you and your patients in the long term, and it's something that is very feasible to be able to do. So I won't go into this too much because Dr. Gonzalez covered most of it, but PSA, UA, PVR, all things that I got at the first appointment, and then I always want to have an imaging. So a lot of times my patients come in with an MRI or a CT scan, and as long as it's within like the last 3 or 4 years, that gives me a sense of the size, if there's any median lobe. If they don't have any imaging, then I'll schedule them for a truss and a cystoscopy, usually at the same time in the office, to get it all done at once. I would say I rarely get urodynamics.